Patient Protection and Affordable Care Act, presented by Kelly Short, Maya Stevenson, Lavia Champagne, Rochikia Newton, and Hanumanth Ravindranath. The Affordable Care Act, ACA, commonly known as Obamacare, was signed into effect in the U.S. in 2010 with the goals of providing better coverage of health insurance for Americans and lowering the overall cost of health care. The ACA aims to increase access to affordable health insurance, enhance the quality of health care and health insurance, standardize the health insurance industry, and decrease healthcare spending. Once completely implemented, this will decrease the number of uninsured Americans by more than 50%. In short, the ACA represents an attempt to reframe the financial relationship between Americans and the healthcare system. So who is newly covered under the ACA? Some examples include children with pre-existing conditions, young adults for whom dependent coverage was extended to the age of 26, low-income Americans, rural communities, unemployed and the self-employed, lawfully present immigrants, Native Americans and Alaskan Natives, people with disabilities, LGBT and their families, and retirees. The ACA achieves this in a number of ways. It removes lifetime and excessive annual limits on benefits, prevents cancellation of health insurance policies, grants support for Americans with pre-existing conditions, requires coverage of preventive services and immunizations, generates consistent coverage documents so consumers can make apples-to-apples comparisons when shopping for health insurance, caps insurance companies' non-medical administrative expenditures, assures consumers have access to an efficient appeals process, and gives consumers a place to turn for support, navigating the appeals process and obtaining their coverage. Devises a short reinsurance program to maintain coverage for early retirees. Organizes an internet portal to assist Americans in recognizing coverage options. And promotes administrative simplification to lower health system costs.
Healthcare exchanges or marketplaces are resources where health insurance plans can be compared for coverage and affordability. Levels of coverage range from bronze at 60%, silver 70%, gold at 80%, and platinum at 90%. Plans are available for individual, family, or small businesses. Individual states determine if they will run their own exchanges or if they will use federal exchanges through healthcare.gov. Currently, 18 states run their own marketplaces, and 33 states use federally facilitated healthcare exchanges. As a result of the Affordable Care Act, states were given the choice to expand eligibility for Medicaid to those who earn up to 138% of the federal poverty line. Currently, 32 states and the District of Columbia have expanded Medicaid, and 18 states have not. In states with Medicaid expansion, premiums on silver plans are on average 7% lower than in states without expansion. This is due to the fact that in expansion states, the average income is higher for those with insurance through the exchanges. As we know, higher income individuals have lower average health risk, which results in lower premiums. The effect of the ACA on premiums varies by state and by type of insurance. For example, the monthly premiums in state exchanges for the silver policies on a 40-year-old non-smoker making $30,000 per year is anticipated to increase by 17% in 2018. After premium tax credits are applied, the actual premium is expected to decrease by 2.9%. We compare that with the employer-sponsored family health coverage plan, which in 2017 rose by 3%, and the anticipated rate for the average monthly premium in the healthcare.gov states, which is expected to rise by 34%. The Avalier group that reported this rise in the healthcare.gov states did point out that it may not reflect the actual rate, as they may be adjusted by the states due to the changes in the cost sharing reduction funding.
There are several variables that come into play in the political debate over the impact of the Affordable Care Act on access. First, there is concern of newly insured patients flooding the delivery system. Through the Affordable Care Act, an estimated 30 to 34 million Americans are expected to gain health insurance. This could generate a heavier demand for services and the potential to create a bottleneck in access. Patients participating in the insurance exchange can experience the narrowing of networks and limited providers. Secondly, due to the influx of patients, an exacerbation of growing healthcare shortages is likely. Workforce shortages in American health infrastructure has been an issue for decades, and the newly insured population is expected to require at least 8,000 additional primary care physicians to meet needs. The potential for increased healthcare spending for consumers has been controversial when discussing the impact of the Affordable Care Act on costs. The transition to the Affordable Care Act and its impact on consumer spending can vary by income level. While consumers with incomes 138% below the federal poverty level and consumers with incomes between 138 to 400% of the federal poverty level experience a decrease in total healthcare spending, it has been debated that consumers with incomes above the 400% federal poverty level will see an increase in their total healthcare spending. These consumers would not be eligible for government subsidies to offset their premiums. Furthermore, the tax provisions developed by the Affordable Care Act is a contributing variable impacting costs. Revenue generated by the new tax provisions help cover the cost of the program, but has affected single filers with an adjusted gross income above $200,000. This tax provision affects 1 million individuals and 4 million couples filing joint returns with incomes more than $250,000. For many years, U.S. medical professionals have strived toward improving practice to provide quality care. To guarantee quality, the Affordable Care Act has moved towards a pay-for-performance model. Under this model, providers are paid or penalized based on reaching care goals. However, the quality of the care in states with fewer physicians will suffer as work shortages worsen. On the other hand, the pay-for-performance system will benefit states that have high physician-to-patient ratios. Additionally, providers working in economically depressed areas may have difficulty meeting benchmarks, which will reduce reimbursements, causing a strain on finances and ultimately producing low performance. The availability of health insurance options is a variable impacting quality. Affordable Care Act provisions such as the requirement that insurers must cover pre-existing conditions has caused insurers to voluntarily leave the health insurance marketplace. Individuals resort to purchasing short-term health insurance policy or elect to pay the Affordable Care Act fine for not being properly insured. Consequently, individuals who are uninsured or underinsured will have poor health, ultimately affecting quality.
Many challenges exist in the implementation of the Affordable Care Act for state and national policymakers. There are challenges such as the establishment of new institutions, enforcing new regulations, education of enrollees, and the experimentation of payment and delivery systems, to name a few. The key challenges stem from the consumer fear of change, the partisan political divide, and the meeting of the projected enrollment numbers. The Obama administration tried to minimize fear of healthcare reform by building upon the existing healthcare structure. They created the Affordable Care Act, keeping in mind to minimize the amount of change in individuals' current policies. This worked for the majority of policies, but to about 5% of the population. Most political analysts saw the non-group market as expensive and unfair to persons with pre-existing conditions. This same issue made it non-compliant upon the implementation of Affordable Care Act to those who made changes to or initiated such policies by 2010. Because of this, individuals who had these policies experienced unwanted cancellations in 2014. This in turn caused the political outcry and increased critics of the Affordable Care Act. The market is only 5% of the population, but still accounted for about 15 million individuals. From the backlash, the Obama administration permitted the plans to continue with extension to 2017. By 2014, 40 states adopted measures to allow renewal of non-compliant plans on individual and small group markets. The Affordable Care Act initially passed on partisan lines with no Republican votes for backing. There are many points on the Affordable Care Act that Democrats believe would sway Republicans over time. Points such as the overall reliance on private insurance, an individual mandate, consumer choice and competition, health insurance purchasing pools, and a major role for states in implementation. There was a great deal of resistance in accepting federal funds after the 2010 elections. In the end, 17 states and the District of Columbia established their own health insurance exchanges prior to the 2013 enrollment. In 2012, Supreme Court decisions made Medicaid expansion optional for states. Medicaid already operated in all 50 states, meaning little accommodation was required, but there was still opposition to expand despite the lure of substantial federal funding. 19 states have not expanded Medicaid, leaving nearly 3 million low-income adults in a coverage gap. The divide has undoubtedly caused the prevention of addressing and rectifying the shortcomings of the Affordable Care Act. Shortcomings like the clarification of premium tax credits and addressing inequity in the states without Medicaid. The Affordable Care Act has already reduced the uninsured population substantially, with expected increasing gains over the next few years. However, it fell short of its projected enrollment numbers. There are estimates that there will be 27 million uninsured persons by 2018, leaving the near universal coverage a distant goal. Some issues arise are from the individual mandates and are not true mandates. Individuals can opt out and pay tax penalties, but those tax penalties are often less than what they would pay if they signed for exchange plans. Many of the policies available for purchase through marketplaces are high deductible plans, making them not so affordable. To make matters worse, there is a struggle to enroll persons who are not very low income. For example, only 30% of eligible persons earning between 201 and 250% federal poverty level, and only 16% of those in 300% or more have signed up for exchange plans. Additionally, the lack of knowledge of the healthcare reform ranges from 35 to 40% of the population. This shows an overall failure to educate and address the population on the policies involved in the reform. Lastly, with the current political atmosphere and the Republican-dominated House and Senate, the future of the Affordable Care Act is largely uncertain.
Overall, we concluded the Affordable Care Act is a good law. Despite the many challenges that exist in the United States today, the ACA has made great improvements. Through the expansion of Medicaid, more than 20 million people have gained coverage. Preventative services such as immunizations, cancer screening, contraception, reproductive counseling, obesity screening, smoking cessation, and a variety of other preventative services are now accessible to the insured at no cost. Mental health care and substance abuse patients can now receive continuing care as part of their regular healthcare benefit package through the expansion of the ACA. The ACA has made great leaps and helped so many utilize resources that were once unattainable. Now, thanks to the Affordable Care Act, more people have access to the care they need in real time. We thank you for joining us. The following slides contain the references used.